We will begin with a small land acknowledgement. We would like to give honor and thanks to the Haudenosaunee and Anishinaabe nations as the traditional inhabitants of the land where McMaster and the Hamilton Family Health Team stand. To say that is to acknowledge a debt to those who were here before us. Oh. And to recognize, sorry, could we go back? Sorry, and to recognize our responsibility as guests to respect and honor the intimate relationship Indigenous peoples have to this land. The dish with one spoon reminds us that we should only take from the land what we need. And we will move on to the next slide. So the goal of this presentation is to be interactive. After each big section that we will present, we want to involve you in discussion and conversation. So we welcome you to make use of the chat to answer any questions or ask any more questions that you may have. So I'll pass it on to Myles to talk a little bit about who we are.
Oh, okay. Well, yeah, so that's me in the blue shirt. So I'm a family doctor in Hamilton, and I wear a few hats in the climate space. Peach Health Ontario co-lead, the executive director of the Canadian Coalition for Green Healthcare, and I'm the medical lead for the Hamilton Family Health Team Green Initiative. Lisa.
Yes, thank you. So I work with Myles for the Green Initiative at the Hamilton Family Health Team, and parallels that I'm a PhD student at the Mary Hearsing School of Global Health and Social Medicine, and I study food prescriptions. So yeah, really excited to be here today.
All right. Well, I see some of the faces here today, and so might be preaching to the converted. I will tell you, we are going through a little bit of the basics on climate change, global warming, and so if you're already an expert, you might want to go off for 5 minutes and get another coffee. The climate crisis is a health crisis. Next slide, please. If you were to Google top 10 planetary health problems, you would get a long list. Here are the top 10, at least in the eyes of the blue and green journey. We focus primarily on global warming and decreasing and mitigating carbon. And we do that because we do think it's one of the most urgent issues of the 10, and it also overlaps with the others where you see the little red leaf. And Lisa, we're going to look back at this. Why is white waste disposal? There's obviously a link there too. But anyway, global warming, climate change intersect with a lot of these. And so it's an important one. I will say planetary health is just a huge thing. Not only because of these 10, but because of the fact that we're talking about the intersection with human health. And of course, the study of medicine is quite vast as well. So lots of intersections here. Next slide. So we have kind of zoned in on sustainable healthcare, and as defined by the World Health Organization, sustainable healthcare is a health system that improves, maintains, or restores health while minimizing negative impacts on the environment and leveraging opportunities to restore and improve it. Next slide, please. What is the basic unit of measurement for global warming? Heat would be a secondary measurement. The primary measurement, next slide, is kilograms of CO2. So CO2 was chosen as the base unit as a global warming potential. How much greenhouse gas does it hold? And compared to other molecules that we typically see within healthcare, methane from food waste, 83 times greater than CO2, nitrous oxide, laughing gas, 273 times greater, and desflurane gas, about 2,500 times greater than CO2. Next slide. I like to show this one, which is a little bit outdated, 1980 to 2015, showing the global increase in greenhouse gases. I show this one because the green piece shows the fact that even though CO2 is a small global warming potential molecule, it is the dominant one in terms of greenhouse gases worldwide. It is, depending on the study you look at, 70, 75% of all our greenhouse gases in green there. And this is primarily from the burning of fossil fuels. Next slide. And in most cases, you can look at the products that we use and see how much greenhouse gas is involved with the making of the product, the shipping of the product, the use of the product, the disposal of the product. And so a mask in terms of CO2 is only 0.02 kilograms. Big deal. What's the fuss? Next slide. And this is Maria, who's an artist from the Netherlands, and we got her permission to use her slide. Her website's on the bottom right there. She underwent a breast reconstruction surgery a few years ago, and she asked her surgeon if he or she would keep all the waste from that operation, about an 8-hour operation. And that is a lot of waste, and that is why we're here today. Next slide. Healthcare is a big contributor to our national carbon footprint, and I'm talking about all our personal footprint, the cars we drive, the houses we live in, all of industry. Healthcare 5%, which is more than the airline industry. Surely we can do better. Next slide. And so the obvious issue here is that healthcare contributes to greenhouse gases, and then greenhouse gases in turn impact our health. These are photographs from the past 4 years in Canada of a hurricane, a fire, a tornado, a flood, and a heat dome. Next slide. So this slide is done by Dr. Jonathan Patz from Wisconsin, who's a professor there. And I just think this is such a beautiful slide. He has global warming in the middle and the impacts of global warming in terms of climate change in red, green, and blue. And then you radiate out from there into how they impact human health. And in the outer layer, we've added a Canadian context. So how these various diseases are seen in Canada. So at 12 o'clock, 1 o'clock, air pollution, which of course is the burning of fossil fuels, but also in Canada, smoke from wildfires. A big, big problem. It's a big problem not only for those who have lung disease, underlying lung disease, but even for those who don't. Vector-borne diseases moving further north in Canada, such as Lyme disease, used to just be at Turkey Point off Lake Erie. Now it's extended to northern Ontario. It's all over Nova Scotia. I'm not going to go through all of these. Mental health, 7 o'clock, super important for all of us, but particularly impacting young people. At 10 o'clock, heat. Heat is the biggest killer in Canada. As you all know now, BC Heat Dome 2021, unfortunately, over 600 people lost their lives. Next slide. So the famous study in the Lancet from 2021, which I think most of you have probably seen, we don't usually look at this aspect of that study, which is the fact that they looked at different sectors and their contribution to the entire footprint in the NHS. And the point here, acute care is 56%. And on top of that, ambulance services are another 6%. So you might argue that acute care is 62% of the pie, huge piece of the pie. Next slide. And so when we started Peach 4 years ago, we started with the Ideal Green facility, and there's an H on the front for hospital. So we did focus on hospitals. They are the biggest contributor. And there's a lot of things that we can do in hospitals. Next slide. This is a primary care talk, so I won't spend a ton of time on this, but this is the low-hanging peach tree, which I think a lot of you have seen now. Gosh, these things become quickly outdated. This was done 3 years ago now, and it was for a 200-bed hospital. If you look around the tree, a number of these things do correlate or are similar to issues that we have in family medicine. For those of you who haven't seen the tree before, the orange fruits are the most significant ones. If you take that initiative, they save over 100 tons of CO2 for a 200-bed hospital in Canada. And the height on the tree is the cost of the initiative. So a few that you may recognize that are orange fruits, big fruits, are board divestments. We've seen universities across Canada moving away from fossil fuel investments. We are reaching out to hospital foundations to see if they can move their money into what we call healthy capital. Having a strategy, leadership strategy, whether that is in your hospital or in your office, is very important. Plant-rich eating is on here, so making a shift in hospitals by even 20-25%. Huge item, also cost saving. And deprescribing, I like to call the number one item. Of course, it's something that we grapple with in primary care as well. Even deprescribing by 5% within your hospital saves roughly $500,000 and is an orange fruit on the tree. Next slide. This slide, I'm really beating home a point here that hospitals are the biggest contributors. So we did this study about a year and a half ago now, looking at the difference between hospitals, long-term care, and home care. In green is data from British Columbia. This is only scope 1 and 2. This does not include supply chain. And even just looking at scopes 1 and 2, which is primarily building energy, hospitals were about 30 kilograms of CO2 for one patient day in hospital. Long-term care was 8.7, and home care was about 1.3. Carrying right along, so hospitals at 30, long-term care 8.7, home care at 1.3. Next slide, please. So what we are saying here, hospitals are the big shiny object on our map here of the green, ideal green community. So we back out a little bit. We're not just looking at the ideal green facility, we're looking at the ideal green community. Hospitals, the big shiny object. But Lisa and I want to shake that up a little bit. Next slide, please. And so we have invented a new concept we're super, super excited about to introduce today. Are you ready for it? We should have a drum roll here. And we've decided to call this concept, next slide, please, prevention. We are introducing a new concept called prevention we think is going to really shake things up in this sector. And we are putting it into preprint in the journal called the International Journal of Doing Obvious Stuff. Next slide, please, Lisa.
Yes, and so how can prevention be delivered? Which is a burning question, as we know. And we came up with, next slide, please. The primary care home. So it is also published in our International Journal of Doing Obvious Stuff. And next slide. Myles?
I get to introduce this one? Okay, and so then we thought, what if somebody actually wants to age and die at home? What should we call that? And so what we're proposing, next slide. We've decided to call it home care. So in this new model, patients will be seen in their homes rather than being hospitalized. Really excited about this publication. Next slide. So we think the big shiny object should actually be clinics and primary care, and that we should be putting more focus there. Next slide, please. Thank you. Okay, so getting a little more serious here, primary care providers prevent and manage chronic disease. They prevent emergency medicine visits and hospitalizations. They coordinate care post-hospitalization. They lead long-term care medical management, and they provide home care. So, Lisa, this is our question. Do you want to take it from here? Yeah.
For sure. So Today we had a technical difficulty with a Mentimeter, so we're going to make it a very interactive space in this Zoom call. We welcome you to use the chat and try and answer this question. So what is the most impactful initiative within primary care when it comes to reducing environmental emissions? So the first one is advanced care planning. The second option is deprescribing. The third is plant-rich eating. Fourth, virtual medicine. Fifth is LED lights, and sixth is reduce, reuse, recycle. So please try and use the chat to give some options. So again, what is the most, oh, okay, so we have some
Awesome.
responses.
Thank you
Plant-rich
so
eating,
much, everybody. Yes.
ACP,
Amazing.
reduce, reuse, recycle, advanced care planning. Reduce, reuse, recycle. Okay, so advanced care planning seems to be making the list along with plant-rich eating and recycling. Okay, awesome. Thanks, everyone. So next slide.
Yeah, can I just stop, Lisa, just have a fun little discussion here and say, do we introduce a bias by talking about prevention just before and then putting them in a certain order? Anyway, we'll think about that. Next slide.
Okay, so this is a recent publication that the team has published. It's called The Environmental Elephant in the Office, Medications. And as you can see, here is the environmental elephant. And this infographic is based on data from the NHS, which points towards the different distributions of emissions towards these different areas of healthcare. And as you can see by the body of the elephant, pharmaceutical production takes up 48%. We also have MDI use and emissions as 13% in the ear area, which is important, but we need to realize that these do not look at the impact that we can have outside of the office. So how about exploring the advice we give? Next slide. And Myles, I'll let you cover this one.
Okay. So the advice we give, when I first saw that NHS thing, my gosh, I think if you've heard me talk before, I just love that NHS publication, Lancet, Imogen et al. So great. And so again, we just pulled the data for the primary care piece and turned it into an elephant, and then we talked about it a bit and what the solutions might be. But on further reflection, I realized that there's a whole bunch of things that really aren't included that kind of fall into the advice that we give within primary care, like plant-rich eating, exercise, and going for nature walks and exposing yourself to nature, social networking, the fact that we do a lot of correcting people on misinformation and educating about that. Over-the-counter medications are not part of that elephant. Chronic disease management, gosh, that is hard to measure, but I mean, huge impact there on primary care side. Advanced care planning, we talked about briefly. How to age and die at home. Next slide, Lisa. So when we did this study, which is at the bottom there, which came out maybe 3-4 months ago. When you turn it into knowledge translation, I think we didn't count, but I think we spent as much as 200 hours on the mathematical modeling here to try to think about how can you look at these different initiatives, and I hope you can pinch this out and read everything on the left there. We actually started out with about 30 possible things that you might do within primary care, really trying to think out of the box. And then we weaned it down to, what did we end up with, about 18 or 19 there. We were trying to mix in some of the usual suspects with some of the things that we don't always think about. I think the thing we did here, which was quite different than other studies, is we included the impact on emergency medicine visits and on hospital admissions, which was a different approach. I will stop and talk briefly about net new physician, which gets some questions asked. This, I would say, this is basically that top bar is a summary of everything that one family physician is doing within their clinic in terms of benefit. We think it's an underestimation because we did not look at or not try to model chronic disease management. Next slide. So if you take those orange, yellow, and green bars from the bar graph above and turn them into fruits, this is what the low-hanging fruit tree for primary care ended up looking like. So you can see those various fruits in the tree. The height on the tree, this is very clinician-centric. The height on the tree is really all about how much time it takes in office to do these things. To recruit a new physician to your community would take a lot of time. AI Scribe saves a lot of time. At least that's what the studies say, 2 to 3 hours a week. People are surprised to see AI Scribe on the tree because of the amount of energy going into AI. But we looked at this a few different ways, and the amount of energy saved from turning off your light and turning off your computer for 3 hours a week actually makes AI Scribe a small green fruit, a needle nudger. There are 3 different colors horizontally here. The bottom zone is the savings, either cost or time savings. So these are the things that if you do will either save cost or money. The font, I mean, there's a lot to digest here. The font color, if it's a black font, it's a clinical initiative. If it's a gray font, it might be office manager, for example, or more of an office initiative. When you get into the middle zone, this is 0 to 24 hours extra per year. This is usually the items that you're usually doing. And can you do a bit more? Can you do 5% more deprescribing than you're already doing? Can you do a bit more advice on plant-rich eating, et cetera? And then top of the tree are the ones that the group of physicians that we surveyed found are a bigger stretch. Reducing over-the-counter meds was almost in that top zone. Countering misinformation takes time. Again, finding a new physician, switching over to green banking would be more time consuming. Next slide.
So here I want to tell you a little bit more about our green initiative and the network of excellence that we are building with all of our collaborating clinics and physicians and clinicians and healthcare providers. So we present the Center of Excellence as this triangle that is foundationally based on the primary care fruit tree that Myles just described, because it provides the background and support for all of the other components. So as part of this initiative, we continue to measure impact, aka understanding what kind of sustainable initiatives are actually implemented across clinics across the country. And this is done through our Green Office Challenge, which is a questionnaire. It takes about 10 minutes to complete, and it is based off of the data that we collected from the primary care fruit tree. To support and facilitate clinics in implementing green initiatives into their practices, we realize that the journey can be complicated and it can be hard to start, hard to know where to move forward and which initiatives should be implemented first, who to talk to. We've designed a Green Initiative Mentorship Program, which links healthcare providers with healthcare providers from our team who have already worked through implementing some of these initiatives into their clinics. And it builds a synergy between the providers to help each other implement and move forward along this journey. And I'll provide a little bit more details about where the Green Initiative Mentorship Program has been over the past year and what the next steps are for it. And finally, we put it all together through our Clinical Networking Hub, which is also a webinar series that we do in collaboration with the Canadian Coalition for Green Healthcare and PEACH, and also Environment and Climate Change Canada, where we invite providers from all across the country to discuss topics, challenges, or successes of implementing green initiatives into their clinics. So altogether, these 4 components build this network of excellence, and we're always welcoming new members. So if any of this interests you, my email will be at the end of the webinar. So please reach out and let's talk about it. Okay, next slide, sorry. And I guess we'll shift into our first area that Myles has covered on the tree, and this is food as medicine and food as it appears as a preventative care measure to that primary care providers have the capacity to embed into their practices to reduce the environmental impact. So, next slide. Yes, plant-rich eating. Awesome. So I want to start by saying that this is the topic of my doctorate studies at McMaster, and so I'm really passionate about healthy eating. And my passion for linking healthy eating to sustainability started from this the story of deforestation of the Amazon and the large cattle farms that are just growing significantly and are taking over all of the green zone in various places across South America. And so this is just one example of a photo. It has been a topic of discussion in environmental classes and throughout my elementary school, high school, etc. And so it's an impactful story to show that cattle farming and farming for meat is impacting the environment visually, like you could see the impact. So next slide. Awesome. The burden of the food industry has been measured in various capacities. For example, this article presents the greenhouse gas emissions per 100 grams of protein. So it's comparing the different types of protein that one can consume and its greenhouse emissions. And as you can see, beef is at the very top with a very significant gap between the second item, which is lamb. And the top few items on this list are actually animal-based products. If we go down the line, we see grains, tofu, ground nuts, peas, nuts, etc. So even from this graph, we can see that by consuming plant-rich proteins, we will significantly reduce the burden of greenhouse gas emissions that happen through the production of these protein sources. So next slide, please. So truthfully speaking, global greenhouse gas emissions from animal-based foods are double those of plant-based foods. And this is a really cool study that kind of compares the consumption and the emissions of these two categories across different geographic areas in the world. So I will post a link to the study if you want to take a look and deepen your understanding. But at the top here with graph A, we have our plant-based products. And at the bottom, we have our animal-based products. And you can see that the doubling of the emissions is visible in multiple capacities. So next slide. We also know that plant-rich eating leads to improved health. We know that plant-based diets can reduce heart disease by 40%, and this is one of the, if it is the leading cause of death globally. So introducing nutritious and plant-rich diets can be a great preventative care measure for not just patients who are living with these conditions, but also for people who just want to live a healthier lifestyle and promote longevity and yeah, health. Next slide, please. And so one of the hurdles often when it comes to understanding how one can decrease their footprint is, oh, I don't want to be vegan. Like, I do not support veganism. I love steak. I love meat. So I will not be shifting my diet. But there's a recent study from Nature that showed that even a slight shift towards a diet that is lower in meat protein and higher in plant-rich protein can significantly decrease one's impact. And so as providers, when you're speaking to patients about what their plate should look like, this is from the Canadian Food Guide, just advise them that even a slight shift towards plant-rich eating can significantly improve their health and decrease their carbon footprint. And again, I can share the citations to all of these studies after this presentation. Next slide, please. So the Hamilton Family Health Team has try to improve the process for having these conversations with patients. And so we have various tools that are available for use, such as more in-depth guides. This is our more in-depth PDF version guide that's published on the website. We also have patient-facing posters, and we have some talking points that can just ease that communication component between providers and patients. Next slide. And another emerging topic within this field is food as medicine. It's been around for quite a few years. It was initially initiated in the United States. And basically, it bridges the gap between people who live with chronic conditions and who may face some socioeconomic factors that could prevent them from eating healthy food. It could be food insecurity, it could be other factors. And so this pyramid is a model that outlines different types of food as medicine interventions, which can range from medically tailored meal programs, which is a type of a very robust program with which measures from baseline to the end of the program. And there's lots of literature showing that there have been improvements of cardiometabolic health factors and food insecurity from participants taking part in these programs. And then as we move along lower down the pyramid, the food as medicine interventions become a little bit less structured and more social medicine centered. So next slide. I want to give a little bit of an introduction to how we can actually choose an intervention like this for our community, and that would be through involving the community in each component. So community-based participatory research practices can be used to choose the approach that can be implemented into clinic, which shows why it's so important to have this interdisciplinary collaboration between institutions, clinics, and patients. Next slide. And that's the topic of my PhD research, which is co-designing a food prescription program at the Hamilton Family Health Team. We're working with the community and for the community, and it's going to be super cool. So stay tuned for some more updates on how that goes. Next slide. So I'm going to open up the floor to some more conversation. How can we do better in prescribing healthy food to patients? Could it be through prescribing it after hospital admissions? Could it be after we diagnose patients with a new chronic condition? Could it be through collaborating with nutritionists or dietitians within the clinics? Are there any other ways that we can improve this? I'll check the chat. Okay, so all of the above, all three. Zara, I see. Thank you. And that's absolutely true. Okay, we'll go to the next slide. We wanted to integrate this question to foster discussion in case people come with ideas. So this is an opportunity. If there's something that we didn't address within this topic that you would like to share, please do. We're always happy to collaborate, discuss, and add more ideas on how we can deliver plant-rich foods. Okay.
Right. And I would just say, Lisa,
Yes.
it's fine. We pause here for a second, see if anybody has something to put into the chat. And of course, hopefully we've got a bit of time and discussion at the end if people want to jump in and actually give us some ideas.
Mm-hmm.
Yeah.
Yes. So we have a comment suggesting more research to comprehend the need for food as medicine. Absolutely. Okay, thank you. We can move on now.
All right. Thank you, Lisa. So medications, yes, one of the big ones for sure. And so that's our pharmacy icon. Next slide, please. And essentially, sorry, the one before that. Yes, essentially this is prevention of polypharmacy. Meds are incredibly important to our human health. So many incredible meds, but we do prescribe a lot of them, and patients do end up on quite a few as they get older. And then there's also the intersection with over-the-counter medications. Next slide. Gosh, it's 3 years ago now, we started a national sustainable prescribing group. Let me know if you're interested. We meet every couple months. We usually have a theme every year. The first year we were making an outpatient or clinic infographic. As I said, I am a family doctor. I don't mean to insult anybody by any means. People have busy clinics, but we're just sort of thinking through how might we do this differently. And of course, it should always start with what matters to you, the patient. You know, what are the patient values? How do they want to manage the illness? Uh, Also, in that category would be making sure we have the right diagnosis. And then you move on to social prescribing. And is there a way we can use social prescribing to decrease medications? When we are starting a med, think back to basic principles. Is it effective? Is it safe? Is it convenient? What's the cost? Then we would move into potentially later on when a patient might be on a lot of meds after a hospitalization or a number of things, and moving into optimization, deprescribing. There's all kinds of resources out there. I don't have Choosing Wisely on there, but of course, Choosing Wisely is another group, all kinds of resources. And then number 5 is sort of the green one. Can we make switches? We're about to add to our website. If you look up UMaker, .com. That's Umaker, Y-E-W, like the shrub, umaker.com. It's in England. They rate meds on their carbon footprint. We are going to bring this to Canada. In the meantime, we do know about MDIs, and we'll talk about that in a second. Next slide. So back to our elephant in the office. The main theme in this article was the fact that legacy meds have the biggest imprint, because these are medications, as you may know, that you might start with the intention of prescribing them for 3 months, and they end up being years, decades that they're prescribed. And can we do better on these ones? Because that clearly has the biggest impact. PPIs, SRIs, MDIs, levothyroxine, benzodiazepines. Benzodiazepines, of course, habituating, and sometimes are prescribed for a patient day one in hospital to help them sleep. And then by the time they come to us as family physicians, they are habituated and they become a long-term med. Next slide. And that was part of the motivation behind doing Journey of the Pill, realizing that if you look at the pie graph of healthcare, production of meds is something like 22% of the pie. That's not just family medicine, that's hospitals, everything, 22%. Why is it so big? We were curious about this. We worked with McMaster Engineering Department to publish this a few months ago, The Journey of a Pill. This is the possible journey. There's many, many journeys, possible journey of a benzodiazepine. And this one comes out to 63,000 kilometers. It's 40,000 kilometers to travel around the equator. So this is more than one lap of the world. There are better ways we can do this. This also falls into resiliency as well. We all know now about supply chain disruptions. Think of all the possible disruptions that can happen with the medication trying to get to British Columbia. Next slide. So over-the-counter medications, Canadians spend $4 billion on over-the-counter medications per year. We also import medications. Many Canadians are new immigrants to Canada and still get medications imported from their home country, may or may not know if those medications are harmful or interacting with their prescribed meds. Do you actually know what your patient is taking? And of course, over-the-counter meds do increase polypharmacy and do increase associated harms. Next slide. Okay, so here are some possible options to help patients with their OTC use. Feel free to throw things into the chat. You can throw more than one number. Really interested in this. Not a lot of research in this area. So much research on prescribed meds and deprescribing. Not much research on over-the-counter meds, how we can decrease over-the-counter meds. And so if you think any of these sound doable, some of the docs that I talk to, this is all anecdotal, think that medication bag checks are doable if you do it in certain ways. Some people just think that is way too overwhelming to be looking through a whole bag of over-the-counter meds. But we are certainly interested in ideas on that one. Next slide. So again, yeah, how can we do better? We can chat at the end. I see it's 12:44, Lisa. I'm gonna have to speed up, aren't I? Next slide. Okay, so we're gonna move into optimizing respiratory health. Read MDI prescriptions here. Next slide. So the basic principles of switching from MDIs to DPIs start with, do you have the right diagnosis? Are you treating a patient with gastroesophageal reflux disease with an inhaler? That's obviously step one. Step two, are the symptoms being well controlled by a long-acting inhaler? Or is the patient using too many short-acting inhalers? And then three would be the switch. Next slide. There was a study done in Canada a couple of years ago looking at exactly these three things. This is theoretical. If you could theoretically improve diagnosis for asthma and COPD and decrease inhalers that way, what is the theoretical decrease that we could make in rescue inhalers? And what is a theoretical, I think they picked 25% switch from MDI to DPI. You would be taking 100,000 gas vehicles off the year in Canada each year. Next slide. I think a lot of the people here probably know about MDIs now. There's been a lot put out there about this, that in MDI, this is a Ventolin inhaler in blue. The emissions from that one inhaler are equivalent to about a 110-kilometer car ride. Next slide. And there are other inhalers which are much better for the environment. DPIs, or dry powder inhalers, significantly less, and soft mist inhalers. Next slide. So I met Dr. Genevieve Ferdet less than a year ago and found out that her clinic in Montreal, big clinic, I think about 40 physicians in that clinic, are working really hard to decrease their numbers. So a few years ago, they were prescribing about 50-50 MDI to DPI. And with a really concerted effort in watching their numbers, they are now prescribing about 72% dry powder versus 28% MDI. So that's the graph over a period of time. Next slide. And this slide shows individual physicians, and they actually have this for all 40 physicians and how the physicians are doing. And the orange bars are MDI and the green bars are DPI. So you can see some docs have switched over as much as about 90%, which is pretty incredible. And so I think they are leading the country. Tell me if I'm wrong. I'd actually like her to do a webinar of her own with her colleagues. Next slide. This one, for sake of time, a little bit redundant, but this emphasizes point two. So of course, it's the right diagnosis, and then point two, using long-acting inhalers wherever possible. Next slide. And some clinics are lucky in Canada. They have this Best Care and Primary Care program, which has respiratory techs who will come to your office and help do some of this education. There are 1,200 primary care providers in Ontario who are accessing this service. This is their website, Best Care at, is that ARGI? .on.ca. So reach out if they might help you. Lisa?
Yes.
Next slide.
Next slide, yeah. There's also a couple of tools available. So this is an online app, inhalerguide.ca, that is super easy to use based on reflections from like our team that's used it. So yeah, we welcome you to check it out and learn about which inhalers and have varying carbon emissions. So yeah, that's the link. Next slide. And we also have a couple webinars coming up very soon, so stay tuned for that. It will be published on the Coalition and the Green Initiative websites. We want to ask this question as well. How can we do better? Does anyone have any reflections after this section?
Yes, and if we don't have as much time as we'd like for discussion, feel free to put things in the chat, reach out to us afterward, and we're moving on to the last, but probably my favorite. Next slide, please. Home care. Next slide. So route number 4 we're talking about today, end-of-life care. Next slide, please. where do you want to be when you die? This would have been one of our Mentimeter questions. And we'll give you 3 options here. Where do you want to be when you die? Do you want to be in hospital? Show of hands. Usually no hands when I ask that question. Do you want to be in long-term care and nursing home? I have had a couple people put their hand up for that one. Or do you want to be at home? Everyone puts their hand up. And of course, some people don't because they don't really want to think about this, don't want to die. I get that too. But 87% of Canadians want to die at home. Next slide, please. Really important to show that or to ask that question before I move into this, nitty gritty mathematics here. So again, this is from a study we published a little over a year ago. These are hockey stick graphs, and these are essentially, in a nutshell, these are all resource use graphs. The top one on the left is polypharmacy. I think I'm going to go through each one of them individually, so I'll save that for later. But they're all hockey stick graphs, all looking at resource use. And here's the point. Resource use is directly related to greenhouse gas emissions. Next slide. We wanted to find data from Canada before COVID. This is the best we could do. We looked at England data, and not surprisingly, polypharmacy goes up with age. And we know that pharmaceuticals equal greenhouse gas, so that goes up with age. Next slide. And health expenditure per capita goes up with age. Next slide. This is now into Canadian data. And finally, days in hospital per person, per age group, per year goes up with age. But the point here is that well, actually go to the next slide. The final one is actually looking at mortality, which looks like the exact same curve as the previous two. And if you look closely at this, you'll see that Canadians start to die around the age of 45, and then that goes up exponentially. And so I think when most people look at those graphs in terms of days in hospital, they would think this is chronic care management. And yes, it is in part, but I think even more so, it is people now into their end of life and dying in hospital. And we just, most Canadians do die in hospital and spend quite a few days of their final year of life in hospital. Next slide. So we need to do better here. This is an upstream. Well, this is also a hospital issue with asking goals of care when a patient gets admitted, but even more so, it's an upstream thing. This is a conversation we can be having in a family medicine office. What are your goals of care? What do you want to do when you get sick and frail and can't live the way you want to live? And we need to have those conversations. Next slide. Almost done. So going back to the very first question about what were the most impactful initiatives, and you all did extremely well on this question, and I'm putting it beside our bar graph. Indeed, advanced care planning for us was modeled to be number one. It's the second bar there. Deprescribing, yes, super important. Plant-rich eating falls a little lower. And then into the yellow range, we just threw one of the yellow range ones, virtual medicine, helpful. And then a couple of the small ones, LED lights, and surprisingly, reduce, reuse, recycle, almost at the bottom, or maybe it was at the bottom. Next slide.
Okay, so I have a few things to say here. So first of all, we have launched our Green Office Challenge 2025. So please, if you are a primary care provider, physician, member of the team, healthcare provider, check out our link on the Coalition website to complete this challenge. It takes about 10 minutes. I'm also happy to hop on a call and do it with you if you have any questions, and it helps you come up with a baseline for your impact. And as we continue doing the Green Office Challenge yearly, you can kind of show your growth in this area. It's super fun, super cool, and we had some awesome responses last year. So we're really excited about this year. Next slide. The mentorship program. So actually, I'm going to ask for you to go on to the next slide so that we hold this QR code up. So the mentorship program was piloted last year and we had 4 clinics participating. The clinics came to us with a hope that they can start implementing green initiatives, but they didn't know what to do or where to start or who to talk to. And so we worked with them over the past year, and this led to certain clinics implementing sustainability into their strategic plan, clinics doing webinars for their staff on plant-rich eating and social prescribing, shifting MDIs to DPIs, alleviating examination table paper, and switching to more sustainable suppliers. So it's been a huge success, and this is part of the team of providers who have been involved with it throughout the year. And it also led to a presentation on some of the impacts of the mentorship program at our Peach Health Conference last year in May. So we are recruiting more participants for this year. So please use this QR code to sign up. It'll just ask for your name and practice. And yeah, I'll reach out to you and happy to work through this throughout the year. Next slide. Autumn, thanks for adding the Green Office Challenge into the chat. We just want to extend our great thanks for attending this webinar. Thank you to the Hamilton Family Health Team and McMaster's Family Medicine Department for supporting this work. I'm always happy to chat, so please reach out to me. And yeah, stay tuned for some of the cool events we'll be hosting. We love to do tree plantings with our providers, and we're also hosting a national climate change is a health issue campaign for Earth Day. So yeah. Thanks so much, everyone. We'll open the ground for questions now.